today's webinar series. This afternoon, we're going to discuss uterine fibroids and the background of uterine fibroids, treatment options, history, how uterine fibroid embolization works, benefits, contraindications, risk, and post-procedure care. Before we get started, I'd like to share a few housekeeping items. For this virtual event, participants are muted. We ask that you remain muted to help us avoid background noise. If you have questions to ask the presenter during the presentation, please type them in the chat window. We'll be answering your questions at the end of the webinar. So again, if you have any questions, just put them in the chat window there, as you can see pointing out. Our awesome administrator, she's the woman behind the curtain, Kirsten, is taking care of everything on the back end. So if you have experienced any technical issues, just type them into the chat window and we'll work to resolve them as quickly as possible. If you miss anything, no need to worry. We'll send out the recording of today's presentation to you and a follow-up email. So Franciscan Health is home to some of the country's most well-respected physicians and clinical specialists. I'm excited to introduce you to two of those experts who will be part of today's session. Today, you will hear from Dr. Saud Ahmed, who is the Director of Interventional Radiology at Franciscan Health Olympia Field. Dr. Ahmed has greater than 7 years of experience as an interventional radiologist. He earned his undergraduate degree from the University of Illinois at Champaign and his MD from Rush University Medical Center at Chicago, where he also completed his radiology residency. He completed his interventional radiology fellowship at University of Michigan, Ann Arbor. Dr. Ahmed loves that he can do cutting-edge, minimally invasive procedures to treat people that would have required major surgery in the past. Also joining us today is Juliana Messer, nurse practitioner for interventional radiology. She will be your point person for questions or scheduling. So before we get the presentation started, let's do a quick poll question to see why you joined us this afternoon. Why are you attending the seminar today? So please choose one of the following. I have never heard of uterine fibroid embolization and want to learn more. I have symptoms of uterine fibroids and want to know my treatment options. I have uterine fibroids and don't want to have surgery. I have family or friends with fibroids and want to learn more. So let's take a moment to give most of our audience the time to respond. Okay, so our answers are in, and it looks like half of you wanted to, you have never heard of uterine fibroid embolization and want to learn more, and the other half of you have uterine fibroids and don't want to have surgery. So that's great, I appreciate that. So you're obviously here for many reasons, and we're excited to offer you some great information. So now, without further ado, please welcome Dr. Saud Ahmed, interventional radiologist, as he shares some great information about uterine fibroids and minimally invasive treatments.
Thank you, Jeff. Thank you, everyone, for having me and to talk about this pretty important topic. I just want to bear with me because this is usually I like to do this in person and see everyone's faces and participate. So, you know, with this virtual life that we now live in this post-COVID era, you know, we're gonna have to get used to it. But hopefully, we can present this information to you all. All right. So again, I'm Dr. Saud Ahmed, one of the interventional radiologists here at Franciscan, and I want to talk to you guys about uterine fibroids. And I know many of you have now participated in that questionnaire talking about, you know, that you don't know much about this procedure, and some of you want to know if you can do something beyond or alternative to having surgery. And those are great questions, and I hope to answer those today. So, you know, we're part of this hospital-based interventional radiology practice here. Next slide. So here's our team. Here are all the physicians on here. There's myself, there's Dr. Arya, Dr. Kevin Keel, and Dr. Anisha Martin. We all love doing this procedure and are very well equipped and very experienced in this. So you can see any one of us in here as well. And this is just a value of our team here. You can go to the next slide. All right, what are uterine fibroids? So you guys may or may not know, you know, a lot of women sometimes have symptoms that are associated with their periods that is beyond the normal amount of bleeding. This includes having very heavy periods and can have some associated symptoms such as pelvic pain, back pain. Additionally, can have other types of symptoms that are associated with fibroids, which is urinary symptoms, constipation. What are these? These are essentially benign tumors. Now, the word tumor usually scares people, but in this case, when you say benign, this really means just an overgrowth of normal tissue. The uterus is an organ with muscles, just like every other organ in the body have different cells. And it's just excessive amount of those that are created. And they come out to be like almost the size anywhere from a grape all the way up to a softball in size. And because of this, you can have symptoms associated with that. Next slide. About 5 to 21% of women in America have fibroids. And many of these women usually present at the age of 35 to 49. Why is this? Because these are slowly growing tumors. They start probably during most women's teenage years, and really they don't really notice it. Or what they may not realize is the heavy bleeding that they actually have is not normal, and they become underreported. But generally, this is the age that it usually presents at a point where it's kind of unbearable. We see this mostly in women, African American women, 60%, and by age of 50, about 80% of them actually do have them. Now, the point of it being 80% doesn't mean all of them are significantly symptomatic, but they do have them. But we also see it within the Caucasian women population, where about 40% by the age of 35 do see this as well. And again, 70% by the age of 50. So let's take another polling question here. So, what are my treatment options for fibroids? Let's see if you guys have any opinions on this.
All right, folks, answer one of the following. What are my treatment options for uterine fibroids? Birth control pills, myomectomy, hysterectomy, uterine fibroid embolization, or all the above? Take a little time here to let everybody get an answer in. Okay, so we thank you all for being engaged by answering our poll questions. So while all answers are correct, all the above is the best answer. So if you answered all the above, you are paying close attention, so congratulations.
Excellent, yes. So it looks like most of you guys do realize that there are multiple ways to deal with this problem. Most of the time when you do have symptoms related to heavy bleeding, the first thing most primary care doctors and even your OB/GYN doctor will probably do is put you on a birth control pill, an IUD, or a shot such as Depo-Provera. This is very common and is the least barrier to entry for any of these things. Many women do well with this, some don't. So the question is, where do you go from here? Well, then the traditional way of treating these things is through surgery. We can do either a myomectomy or hysterectomy. Myomectomy is when they do it where they actually remove part of the fibroids from outside of the uterus, or they actually go within the uterine cavity through a dilatation curettage and, for lack of a better term, scrape the inner lining of your uterus and remove the fibroids that are problematic. And that has its own side effects and possible complications. Hysterectomy is major surgery. They're truly removing your actual your uterus itself, and that in itself has its own recovery time. And we'll get into all the different pros and cons to these procedures. And the final one that we're going to talk about is the minimally invasive treatment, uterine artery embolization. Next slide. So most people have no idea this even exists. And most people think that this is some kind of experimental thing. Absolutely not. This was started in 1995, and the data at that initial study showed that there was 100% of success rate with the number of patients that were done. And the United States, the first actual true procedure was done in 1997. I know for many of us that seems like it was just yesterday, but that is almost over 20 years ago. And ever since then, we've been in far more. See the next slide. In terms of the fibroids, there are different locations of where these fibroids occur. You can have a fibroid within the actual muscle itself, which we call an intramural fibroid. We have a fibroid that essentially abuts the lining of the external lining or the outer lining of your uterus, called a subserosal fibroid. Then you have some that are, again, abutting or bulging into the inner part of your uterus where you have your endometrial lining. That's the lining that sloughs off every month during the period. So the submucosal fibroid actually are the ones that cause most of the bleeding issues more than any of the other fibroids, but they all do have the same problems. Of those fibroids, the submucosal and the subserosal, there are two variations. Then those are the pedunculated ones. What that means is that the fibroids have a stalk that it kind of grows out of. And those are important, and we'll get into why that's important when we talk about when we see you in clinic. So this is, I apologize, I know it's lunchtime, we really shouldn't be showing pictures like this, but you know, this is when a surgeon goes in to actually look at a uterus that has very large fibroids, and these are probably multiple subserosal fibroids that are bulging out, and these are the ones that actually cause the mass effect. That's the stuff that you get constipation, or you get that bloating feeling, or even the issues of frequent urination. These are the fibroids that would be causing it. All right, next slide. So how does this whole process work? Why do we think that this works? Well, the idea of the blood supply to the uterus is essentially taken up majority by these fibroids. The fibroids act like a sump. They try and seal away most of the blood supply. We use that to our advantage in treating these things. So when we do try to eventually, and we'll talk about how we block the blood supply to these fibroids, we know that most of the things that we treat, that we're going to give, are going to go to those fibroids and preserve the blood supply to the rest of the uterus as well. How do we go about doing this? When we do the procedure itself, we can access two locations in the body to navigate our catheters and wires to these fibroids. Traditionally, we'd like to go through the groin, where we access the artery there, and we can navigate it. But now we're more and more moving towards accessing the wrist and the artery over there and getting towards the fibroids. Both have their pros and cons, but with the wrist version, we'll talk about why that's beneficial in some cases, because you can get up and start walking immediately versus the other option. So once we do get access, we navigate a catheter as close as we can to the blood supply to the fibroids, and we deploy these tiny, tiny particles. We're talking about in the order of 500 to 700 microns. So these are smaller than the width of a hair. And these particles go into the fibroid and close off the blood supply. And eventually, the purpose of doing this thing is to cause it to shrink and become inactive, because these are very active parts of the uterus. And these are the products we use. They're called embospheres. So this is probably more, for me, this is what exactly I see when I'm in the procedure doing this, but this is what we call an angiogram. And this is when we put a catheter into your guy's body, into the artery supply, and we inject dye contrast, and we get a complete picture. This is a normal pelvis. So here in the center part of this of the screen, just as the arteries kind of break into a left and right side, the blood supply that goes into the midline or the middle of the pelvis would be where a fibroid would be. In this case, this is a total normal one. Now, in this over here, on this picture here, if I can draw your attention to the right side of the screen, that image there that almost looks like a round ball in the pelvis is the uterus with the fibroid. So as you can compare it to the picture on the left, where it shows really no blush compared to that one, the one on the right shows this blush. And that's because that's the blood supply that's being taken up by the fibroid itself. We use this picture here to navigate and to block off the blood supply to the fibroid. So the idea is that we take the picture that we see on the top of the screen here, where we're seeing all those tiny, tiny blood supplies to the fibroid, and if you look at the picture below it, you see a lot of that is gone. But yet we're preserving the major blood supply to the uterus itself. So a lot of people would think, oh, are you going to cut off the complete blood supply to my uterus and my uterus is going to be completely suffocating? Absolutely not. That is not the purpose of this procedure. We have the technical know-how and also the understanding of the anatomy to know to get to specific vessels that are supplying the fibroid and block those off while preserving the rest of the uterus. And again, this is just another picture showing the same thing. And again, we're just seeing more and more examples of the procedure we do and how we treat these things. So this is a pretty important slide here. This is an MRI. And the pictures that we're seeing here are before and after fibroid treatment. The way that this picture is shown here is that we're seeing your body, if we kind of went through a slide through the side of your body. So we're looking at your uterus from its side here. Those large, darker circles that we're seeing throughout are fibroids that are active and growing in a woman here. It is actually the right side of that image is the spine, and the front is the belly. And you can see it's pushing on this person's bladder, which is on the bottom of the pelvis, and it's also pushing on their rectum. So this lady would have a lot of symptoms associated with that. On the right side of the screen is one that's been treated. So the bladder, which is the white the white structure just anterior, just in front of the uterus itself, is now that pressure has been relieved on the bladder. And even the pressure has been relieved in the spine. So back pain has been relieved in this patient. Constipation has been relieved. But more importantly, her bleeding has been relieved because those are all shrunk and has become decreased in size. So an MRI is actually very important for us before doing this procedure. It's going to allow us to give us a sense of the number of fibroids, how big they are, and their location. And then we follow up after treatment with an MRI 6 months, usually after the procedure, to let us know that we got everything that was treated, and it can actually give us if there's anything that has not been treated, something for us to know. All right. So, is this procedure even worth doing? Is there any data about this? Absolutely. In the American College of OB/GYN, in the literature of most gynecologists, even as early as 2008, it showed that there's good and consistent evidence of this, and the outcomes has been excellent for this procedure. Let's move to the next. And this is going to be a multiple trial, so we'll move on to the next slide here. And we'll next slide here. And we'll do one more slide. And the next slide. All right, great. So the past few slides, they get really technical, but the overall data is what they're trying to show is that the outcomes in terms of the decrease in the bleeding is equivalent between surgery and this procedure. But what benefits fibroids versus the surgery is one, shorter hospital stay, shorter recovery, and no significant major complications and difference. Next slide. So there's a historical data that's been done called the Fibroid Registry, which initially, and this is back in the early 2000s, they enrolled 3,319 patients. And these were all followed and to see how they did after this procedure itself. Next slide. And this is what the data really showed. It showed that in fibroid embolizations, that the hospital stay was less than a day. So we usually keep you here for 23 hours versus hysterectomy, which people are here on average for 2 days, and same with the myomectomy. Most people can return to work in about a week to 2 weeks versus about a month for a hysterectomy and myomectomy. The minor complications are half of the other procedures, and the major complications are a fourth of the hysterectomy. So clearly, we're seeing a procedure that has significant benefits and really lets you get back to your normal activity and living, which makes sense. We're talking about major surgery here compared to something that is literally the incision that I make in the groin or in the wrist is 1/4 of an inch, and most people don't even see it after a month. Next slide. So how does the procedure work on the day of? So we initially will see you in clinic, and we'll go and talk about that soon. But once you do come here to the hospital, typically we can start a special pain pump for you to manage the pain symptoms after the procedure. Some women do elect to have anesthesiology put an epidural in there. The reason behind this is while the procedure itself is not really that painful, afterwards, when we do cut the blood supply to the fibroid, there will be pain that can be associated with the inflammation. As you can imagine, they don't like the idea that you're cutting their blood supply. So because of that, they're going to react. So the pain is for the control is for that. Again, we access the groin or the arm. With the groin, it's the traditional way of what we usually do. After the procedure, we typically want to hold pressure on the groin for about 20 minutes, and then you have to keep your legs flat for about 4 to 6 hours. So, but generally, that's the main conventional way of accessing these fibroids. Very low risk of bleeding and infection from that side. With the wrist, we typically go through the wrist if the vessel size is big enough, we usually have a test to make sure that all that is adequate. And if you're a candidate for it, a lot of women do elect for that because after the procedure, you don't have to lay flat. You can get up and start walking immediately. So that's actually very beneficial, unless you have an epidural. During the procedure itself, most women will usually give light conscious sedation. So that's twilight. Procedure is not painful. The worst part is the numbing medication in the groin. But afterwards, really, you don't feel what's going on. You're not going to feel us navigating the catheters into your pelvis and feel the beads coming in. You're not going to feel any of that. It's more just to help with some of the anxiety associated with the procedure itself. Afterwards, we usually advise that patients take a week off of work. Most people are back to their normal energy level in 2 weeks. So who are the most ideal candidates for this procedure? Women with symptomatic fibroids. So that's the bleeding that's longer than 5 days, heavy bleeding, patients who have cramping and pain associated with it, women who have bleeding that occurs between the cycles. So these are all patients with fibroids that are symptomatic. Of course, it's women who want to avoid surgery. Although I will argue, and I think that's what the data is showing, is that this isn't something you should avoid surgery with. This is the first line after using conservative therapy with birth control pills before jumping to surgery. I really think the importance of preserving your uterus is actually there. And so one can argue that, you should do this before you have to go for hysterectomy. And the nice thing about this is that if it doesn't work for you, which it's rare, the data shows that 95% of women who do this procedure will have benefit. But if you're one of the 5% that doesn't, it doesn't stop you from getting a hysterectomy. In fact, it may even help that procedure. Who are women who are not really the best candidates, or are not best candidates for surgery, are also women who we would like to treat. These are women who have issues with extensive medical history, low blood counts, which are anemic. And so these are all these different things. About fertility. Now, this is going to be the important part of talking about this is, what will fibroids do with my fertility? The reality is we don't know. And the reason why we don't know is because we can't ethically do a study to show if someone can become pregnant before or after having this procedure. That's why we do want women to know that if you do this procedure, you potentially could harm your chance of fertility if you've had multiple children and you desire more. Now, there are women who come to us who cannot have children, likely because of their fibroids, creating an environment in their uterus that they can't complete a pregnancy to term. Again, there's no data, but anecdotal evidence have shown that occasionally this procedure has actually helped with pregnancy. That women who were not able to carry a pregnancy to term after having this procedure may. I can't promise that, and that's something that's really important to know. But that being said, again, the most ideal patients are those who are finished with having many more children. Next slide. Now, who are people who would not qualify for this procedure? If you have an active pelvic infection, we're not going to treat you at that time. However, it doesn't mean that we never will. We just wait till that eventually clears. Contrast allergy. Now, contrast that we give can some people have some allergies to it? And you would probably know beforehand, but if you haven't, we would probably need to, we could, additionally, if you have even a mild allergy, we could potentially prepare for that. If you have any issues with your kidneys, you have renal problems, those things are because the contrast itself can affect the kidneys, but many a times we can adjust accordingly. Other things like having issues with bleeding, issues with having a tumor or a mass, any malignancy, these are all things that are important. Obviously, if you're pregnant, we don't want to do this procedure. And again, we talked about the desire for fertility. What are the complications? Pretty low. Vaginal discharge is something that is probably more common than anything, only because if there is the uterus, if the fibroids are near the endometrial lining or the inside of your uterus, it may start kind of shedding off, so you might get some discharge from that. Infections are pretty low risk. We give antibiotics beforehand. In ovarian failure, again, this is very theoretical. It's in very rare circumstances, I believe in 0.5% of the population, women do have a common blood supply from the ovary to the fibroid itself. And so if that situation comes up, potentially it could cause the ovary to go into menopause early. For some women, that's not an issue. They kind of want to go to menopause anyways. And so that's something that we usually talk about in our clinic planning. Again, we talked about allergies, groin side complications, and the reoccurrence of fibroids, about 10%, pretty rare. It took about 20, 30 years for this fibroid to get to this point anyways. And so most women in their 30s, 40s, 50s are getting closer and closer to menopause. Menopause actually is the ultimate cure for fibroids. And once you hit menopause, no more fibroids will grow again. So rarely do this reoccur. So when we come to see you guys in clinic, we'd like to see you in clinic. We don't just jump to the procedure. So we have you come schedule us. And again, this can be done directly to us. You don't have to go through an OB-GYN to come see us. You can even go through your primary care doctor and come and see us. Or you could even call us directly and schedule it. Most insurance will let us see you first and let's evaluate first. If you have heavy bleeding, we can evaluate that and figure out what your overall cause is if you have fibroids. We'll get an MRI initially when we see you to make sure that you do have these fibroids and that their location is in a place that is can be treatable. We do talk to and we work with our OB-GYN after we see you to make sure if there's any sort of things that need to be tested out. Some of them would like to have a biopsy beforehand. These are all things just to make sure that we're all in the loop. And then we do schedule up your follow-up visits after we do the procedure. And then once you have the procedure done, we keep you in the hospital overnight for about 23 hours. We do pain control, make sure your groin side or your wrist side is okay. And when we do have you leave, we give you medications to help with the inflammation and also any nausea that could be associated with this. So again, uterine fibroid embolization is an effective and a very durable treatment for this. I really would impress upon everyone here that apart from starting with something like an oral medication to help with your bleeding, that this really should be the first line in getting your fibroids treated. Try to avoid surgery if you can. Surgery has its own complications. You know, it takes longer recovery. You can get things like adhesions, and there are a lot of post-surgical complications that we could avoid. The fibroid embolization procedure truly is very minimally invasive. We talk about the incision is 1/4 of an inch, and most people don't even have a scar left afterwards. We have 90% success rate in our clinic. We've done hundreds of these. I would say we were closer to 99% in our success rate. And it's got low complications, and we follow up with you guys before and after. And really, this is something that that should be more prevalent in our community. If you guys are interested or have any questions, please call our office to schedule. You can talk to our nurse practitioner, Juliana Messer. This is her office number. You can call her directly as well, and she can field any questions that you have.
Very good. Thank you, Dr. Ahmed. That was some great information, and I hope our audience felt the same. So now here is your opportunity, everybody, to get your questions answered. So again, go to the chat section and put your questions in. So let's give everybody a moment to submit their questions. All righty, here comes one. Is uterine fibroid embolization covered by insurance?
That's a great question. Yes, most insurance companies do cover uterine fibroid embolization. Most insurance companies acknowledge that this is a very well-researched and very effective treatment for this that's minimally invasive and more cost-effective than surgery with less complications. So majority will. That said, when we see you in clinic, Juliana is an expert on this, and she would be able to make sure that everything should be covered beforehand.
Very good. Thank you for that answer, Dr. Ahmed. Okay, here comes another question. If I have uterine fibroid embolization, does that mean I won't be able to have a hysterectomy in the future?
Great question. No, it does not mean that. It means you still could have a hysterectomy in the future for whatever reason. If you have incredibly large fibroids and we're able to shrink it, but it's still not shrunk enough for your comfort, it does not preclude you from having a hysterectomy. In fact, we would actually reduce the blood supply of the fibroid, and that would help the surgery become less complicated.
Very good. Here's another question. Does Franciscan have a physician in Indianapolis that does this procedure?
That's a good question. I mean, my understanding is we do have our Franciscan sites in Dyer and Crown Point, and our colleagues there do perform this procedure, and I believe also Michigan City, but in Indianapolis, I'm not familiar with physicians there if they can do that.
We'll have to delve into that further for that participant, but thanks for that answer. Right now, any other questions out there? If you do, please take a moment to put that in the chat box. If there's questions afterwards, obviously you could still pose those questions and we could follow up with those answers later on. But it appears at this time, there's no further questions, Dr. Ahmed. So we want to thank you for your expert and sound advice and for sharing so much helpful information with us this afternoon. So thank you again, Dr. Ahmed. For all those,
thank you everyone for attending, and I really do appreciate taking your time out to do this.
Very good. Someone did mention that they had a question prior to the presentation. Oh, wait, we got one more. You got time for one more, Dr. Ahmed?
Oh, hey, yeah, absolutely.
Okay.
I'm not sure. So for Sally, she mentioned a question before the presentation. If you can resubmit your question, I think it may have gotten lost. We can answer that. LaToya, your question, which we could answer, is you're taking 10 milligrams of progesterone daily. Would you recommend fibroid over medication? Good question. That really comes down to you, LaToya. It depends on how that's working for you. A lot of women have problems taking birth control pills. They get symptoms that are associated with nausea. It affects, some of their other parts of their body. Additionally, being on a birth control pill does increase your risk of blood clots. So these are all different things. Some women are okay with that. Women are okay just taking their birth control pills and controlling their bleeding. However, if any of that falls in line in the issues that you have intolerance to the birth control pills, or it's not adequately controlling your bleeding, or you have bulk symptoms, that the progesterone is not going to help if you have a large fibroid that's pushing on your bladder, pushing on your rectum. It's really the birth control pills really just help with the bleeding and the activity of the fibroids. Then yeah, a uterine artery embolization or uterine fibroid embolization would be beneficial for someone like yourself.
Very good. I'm assuming that's our last question. So again, folks, thanks again for joining us today. We'll send you an email with recording of the session. Feel free to watch it again and share it with others who might find it helpful. You'll also receive a survey about the seminar and its content. Your feedback is truly important to us and will help make future seminars better. So please take a few moments to fill that out. So on behalf of everyone at Franciscan Health, thank you for being with us and have a blessed remainder of your day. Thank you again, Dr. Ahmed, and thank you everybody for joining us. Take care.
All right, take care, guys. Thank you.
Bye-bye.